Hi there, welcome to this warm-up review. Let's get started with the first question. Which dermatologic findings is seen in each of the following stages of syphilis? So for skin findings in syphilis, your primary syphilis will have a painless chancre. Secondary syphilis will have a maculopapular rash on the palms and soles, and also your condylomata lata. And finally, tertiary syphilis will have gummas. Be able to make those distinctions for sure. Next question. Which antihypertensives are commonly used during pregnancy? So the mnemonic here is hypertensive moms love nifedipine. Hydralazine, methyldopa, labetalol, and nifedipine are your answers here. Next question. What does each of the following cells of the GI tract secrete? So the G cells of the stomach secrete gastrin. The I cells secrete cholecystokinin or CCK. S cells secrete secretin. D cells secrete somatostatin, and the parietal cells of the stomach secrete both gastric acid and intrinsic factor. Okay, that's it for this warm-up review. Let's move on to the lecture.
Hello everyone and welcome to our Step 1 video on amino acid disorders. It's time to find out which of you have a potentially devastating disease and which of you just naturally smell musty and have funny looking pee. Okay, so amino acid disorders. Today we're going to first cover PKU, phenylketonuria. Now PKU is definitely high yield for Step 1. It's a 4-star topic. You're very likely to have a question on PKU. So what is it? Well, there are two ways to have PKU. You can either be deficient in the enzyme phenylalanine hydroxylase, which converts phenylalanine to tyrosine, or you can be deficient in the cofactor for phenylalanine hydroxylase, which is a hard one, tetrahydrobiopterin. And so in this disease, just like with any other metabolic disorder, the next product down the line is going to be deficient, and in this case it's going to be tyrosine. So tyrosine actually becomes an essential amino acid at this point for these patients because you can't make it on your own anymore. You have to bring it in from the outside. And also, you don't want to give these patients things like phenylalanine because it's just going to build up. That's going to be the other big problem. They can't process phenylalanine, and it's going to result in something called phenylketones. So what are phenylketones? Well, phenylketones include things like phenylacetate, phenylactate, and phenylpyruvate. So with PKU, these phenylketones build up when you eat foods rich in phenylalanine. But realize that the actual neurotoxic effects are actually related to the high levels of phenylalanine and not actual the phenylketones. And as a result, this can cause things like growth retardation, intellectual disability, seizures, fair skin, eczema, and then the all-important musty body odor. And that's a big giveaway on a lot of your test questions. Now, PKU is a disease that you want to diagnose as soon as possible so you don't get these manifestations. So for this reason, we actually screen infants at 2 to 3 days of life, very early on. Now, why can't you screen these infants just right at birth or prior to birth? Well, you have to actually wait for these phenylketones to build up to a certain measurable level in the urine. So after delivery, moms can actually provide tyrosine in utero to the baby. But after delivery, as the baby is getting phenylalanine in the breast milk, it's going to start building its own phenylketones in that urine. And then you can actually start testing for these in the urine as well. So how do we treat this? Well, patients should avoid phenylalanine to start with. So what is high in phenylalanine? Well, a lot of great things, unfortunately. Aspartame, which maybe isn't that great, it's just an artificial sweetener. But the other things are really important. Things like dairy products, meat, fish, chicken, eggs, beans, nuts. So a lot of great things have phenylalanine in them. And then again, you need to add tyrosine. That was our deficient problem in this diet because they will become tyrosine deficient. Again, it also may not be an enzyme deficient problem. It could be that cofactor. Remember, it's that tetrahydrobiopterin that could be deficient in this situation. So that's going to be essential as well. So supplementation of that tetrahydrobiopterin could be necessary as well. And this needs to be accomplished within really the first 3 weeks of life in order to prevent a lot of the characteristic effects of this disorder. Now, what would happen to the infant of a pregnant mom that has PKU, that's been managing her PKU her whole life, and then for whatever reason, while she's pregnant, decides that it's too difficult and she doesn't want to manage it very well? What would happen in that case? Well, the infant would have microcephaly, intellectual disability, growth retardation, congenital heart defects as well. So these phenylketones and phenylalanine are going to be very toxic to that developing fetus. All right, so let's move on to another amino acid disorder called alkaptonuria. And alkaptonuria causes something called ochronosis. And so what is the enzyme that's deficient in this situation? The enzyme here is homogentisate oxidase, or also known as homogentisic acid oxidase. So these patients can't degrade tyrosine normally. Now this is an autosomal recessive disorder, but it's not quite as severe as PKU. They have this ochronosis taking place where they have homogentisic acid, and that's going to build up in the urine and in the connective tissue. And homogentisic acid is a brown pigment, so the connective tissue becomes dark. The sclera can become darkly pigmented with spots as well, and the urine's going to turn black as it's exposed to air. And they can have arthralgias again because of that homogentisic acid. It's being deposited in the connective tissue in the joints, and that's actually toxic to the cartilage and can cause pain. Now, one way to remember alkaptonuria, remember alkaptone has dark connective tissues, dark sclera, black urine thickening. So I think of Al Capone, alkaptone, kind of wearing a black dark suit, and that's one way to remember that. A little bit of a stretch, but I think it's so good. Now, there isn't really much in the way of effective treatment. Vitamin C supplementation might be helpful. Dietary restriction of phenylalanine and tyrosine can be tried. But again, treatment is not very effective at this point. Now let's move on to albinism. So here you can either have a tyrosinase deficiency or a defective tyrosine transport. If you can't get tyrosine into the cell, then it can't be metabolized into melanin. And so those are two ways that you can have albinism through the amino acid pathway. All right, so another amino acid disorder is homocystinuria. So like the name implies, this is having homocysteine in your urine. So why would you have this? Well, homocysteine can be converted to a cystathionine, and then cystathionine gets converted to cysteine. Now, homocysteine can also be converted to methionine. Now, you can have homocystinuria if you have problems with either of these processes. Now, the conversion of homocysteine to cystathionine requires the enzyme cystathionine synthase, and that requires cofactor B6. So, homocystinuria can be caused by a deficiency of cystathionine synthase or by a decreased affinity of that cystathionine synthase for that peroxyl phosphate, that B6 cofactor. So, if the enzyme doesn't interact effectively with that B6, then it's not going to work either. Now, that other pathway and problem can occur if you can't convert homocysteine to methionine. So if you have a deficiency of homocysteine methyltransferase, you can also get homocystinuria as well. So as you accumulate more and more homocysteine, this is going to build up in the urine, and that's going to be where you're going to get your diagnosis most of the time. So what are the clinical manifestations of this? Well, in addition to homocysteine in your urine, these patients will have intellectual disability, tall stature, osteoporosis, kyphosis, atherosclerosis, and subluxation of the lens of the eye. Now, in what other disorder might you have that subluxation of the lens? Well, think of Marfan syndrome. So two genetic diseases or disorders in where you're going to have that lens subluxation. Now, homocystinuria and Marfan syndrome are still a little bit different. The one difference between the two is that we see a downward lens dislocation in homocystinuria, and then in Marfan syndrome, we see an upward lens dislocation. So how do we treat homocystinuria? Again, you have to know the metabolic pathway. You have to get around that metabolic pathway. If it's a cystathionine synthase problem, then you're going to decrease methathione in the diet. You're going to increase cysteine in the diet because you might get deficient at that point. You're going to increase B12, folate, and especially B6. Remember, B6 is that cofactor, very important. So diet should be high in B12, folate, B6, and cysteine to bypass that pathway, and then low in methionine. Now, we're talking about homocysteine. I also want to mention another substance called SAM, or that S-adenylyl methionine. Now, why is S-adenylyl methionine important? And this is more of a biochem question rather than a problem with a disorder. Well, SAM transfers methyl units, and the transfer of methyl units is particularly important for the conversion of norepinephrine to epinephrine, and also for the synthesis of phosphocreatinine. And so for those two interactions, you need SAM. Now, what else do you need to know about the S-adenylyl methionine? Well, it's made from ATP and methionine. So that's how you get SAM. And the regeneration of methionine is dependent upon things like B12 and folate. So if you don't have B12 and folate around, you're not going to have very much methionine. And without methionine, you can't make that S-adenylyl methionine. So if you can't have S-adenylyl methionine, you're not going to be able to make things, as we said before, those phosphocreatinine, your epinephrine from norepinephrine. So that's what you really need to know about SAM. There's this long process of you're deficient in one thing, it's going to mean you're going to be deficient in another thing. Now, the next amino acid disorder I want you to know about is cystinuria. Now, cystinuria is a defect of the renal tubular amino acid transporter for what we call COLA, C-O-L-A. And this is a mnemonic for cysteine, ornithine, lysine, and arginine. Now, this transporter is normally found in the proximal convoluted tubule of the kidney. But with cystinuria, you have a defect of that COLA transporter in the proximal convoluted tubule. So why is cysteine in your urine a problem? Well, you can form cysteine kidney stones. And the way you want to prevent this and to treat this is with something called acetazolamide. So acetazolamide is a carbonic anhydrase inhibitor that is going to alkalize the urine and prevent the development of those kidney stones. Now, one thing to clear up is the difference between cysteine and cysteine, and they're spelled differently. So there's the C-Y-S-T-I-N-E, and then there's the C-Y-S-T-E-I-N-E. So one with an E, one without an E. So cysteine without an E is an amino acid, and it's formed by two cysteines with an E bound together by a disulfide bond. So it's probably not too important, but don't get confused. They're not actually the exact same thing. One is made up by two of the other. So sometimes I think we're our own worst enemy when we're naming things in medicine. Now, another amino acid disorder that puts weird stuff in your urine is called maple syrup urine disease. Now, in this disorder, the urine is actually going to smell like maple syrup. And the reason why is because it's filled with the branched chain amino acids isoleucine, leucine, and valine. Now, one mnemonic that you can use to help you is I love maple syrup. So the I, that L, that V, to help you remember the maple syrup. So the I is for isoleucine, L is for leucine, and V is for the valine. Now, this comes about because of a deficiency in the enzyme complex called the branched chain alpha keto acid dehydrogenase complex. That's a long one. Now, it's supposed to be breaking down all these branched chain amino acids. And if the enzyme is deficient, these branched chain amino acids don't get degraded like they're supposed to, and they build up in the urine and in the blood, along with the corresponding branched chain alpha keto acids. Now, this causes a lot of the same symptoms we've seen in all these things: intellectual disability, CNS defects, high mortality rate as well. Now, what about Hartnup disease? So this is the last disorder that we're going to cover. Hartnup disease is an autosomal recessive defect of a transporter in the intestine and the kidneys, and that's supposed to be transporting neutral amino acids like tryptophan. And this causes tryptophan to be excreted in the urine and not be absorbed in the gut. So what happens when you don't have tryptophan? Well, if you don't have tryptophan, your body can't make niacin. And when your body can't make niacin, you get pellagra. Now, we'll talk about pellagra in more detail with the vitamin deficiencies, but this is a vitamin B3 deficiency. And when you're deficient in vitamin B3 or niacin, it causes that triad, the big Ds. So the three Ds: dermatitis, diarrhea, and dementia. So these are called the big Ds, or the three Ds of vitamin B3 deficiency. Remember, it's going to be dermatitis, diarrhea, and dementia. Okay, so whenever we have unnecessarily complex names to remember, that means that we need to review all this in Lewis Notes. Hello everyone, welcome to another Lewis Notes. We're talking about amino acid diseases here. We've got our big amino acid diseases here, and what we're looking at are the red here, we have the enzymes that are deficient, and then in the blue we have some high yield stuff that I want you to remember as well. So write this stuff out with me. It'll be an easier way of remembering all this stuff. So first we're going to start with our red enzymes here. We're going to go backwards. First we have the homogentisic acid oxidase. So you look at that and you think, whoa, they both have homo in them, and they must go together. This actually does not go with homocystinuria. This actually goes with alkaptonuria. So remember, the homogentisic acid, all that stuff goes with alkaptonuria. Next we have the alpha keto acid dehydrogenase. And that one is going to be going with our maple syrup urine disease way down here. So lots of long words on that one. Tyrosinase is going to be going over here with albinism, so you can't make your melanin at that point. Decreased tryptophan. So if you have decreased tryptophan, you do have to worry about Hartnup disease. That's what is going to lead to that one right there. Phenylalanine hydroxylase. That one's pretty easy because the phenylalanine makes you think of PKU, phenylketonuria. Cystathionine synthase, that's going to be over here by homocystinuria. You could get confused with that one and think it goes with cystinuria, but it actually doesn't. Next we have B6, and that B6 is going to go along with homocystinuria again. Remember, that was another kind of cofactor that went with that one. The big COLA, that mnemonic that was used to help remember where this is happening in the kidney, that's going to go with cystinuria. And then that tetrahydrobiopterin, that really super long one, is another cofactor that then goes along with PKU. All right, so now let's take a minute and let's look at the high yield stuff that you got to remember in regards to all this stuff, because you can remember the enzymes, but you have to also remember sort of where this is taking you and all this type of stuff. So the first one, we have niacin. So niacin is going to be associated down here with that heart disease. Remember that will decrease tryptophan. You're not going to be able to make much niacin, and then you get your 3 Ds. Remember what the 3 Ds were? Dermatitis, diarrhea, dementia. Sweet smelling urine, that one's pretty easy because it's just in the name there. So maple syrup urine disease, that one's pretty easy. The musty smell, always go with PKU if you see musty smell on a test right there. Dark urine, if you see dark urine, you're always going to want to go to alkaptonuria, especially if that urine's been sitting out. Also dark sclera, also dark connective tissue and that sort of thing. Increased skin cancer, very easy to go here with albinism. Lens dislocation, this one's a hard one to remember in my opinion. And remember, that's going to be that downward lens dislocation. So that's going to be with homocystinuria. And then the cystine stones, that's going to go along with that cystinuria. Remember, you're going to be getting a lot of those types of stones in regard to that, and you can use acetazolamide to help treat that sort of thing. All right, so that's the high yield stuff. Those are the high yield enzymes. I hope you can remember all that type of stuff, and then you'll be okay. All right, that's going to be it for the amino acid disorders. Let's go ahead and go through the end of session quiz together. First question here, a full-term neonate feeds poorly, is hyperactive, and has a musty odor. What is the diagnosis? So the musty odor is something you got to remember here. That's going to be your clue for PKU, phenylketonuria. Next question. A patient with PKU should have a diet low in phenylalanine. What other dietary modifications should a patient with PKU make? So first, you want to probably increase tyrosine because you're going to be deficient in that because you're not producing very much of it. And then you're also going to want to replace the tetrahydrobiopterin cofactor if that is also deficient. Next question. A middle-aged man has dark spots on his sclera and has noted that his urine turns black when left sitting for a period of time. I don't know why he's doing that, but it's happening. What is the diagnosis? So this is an easy one. That's going to be that alkaptonuria. Next question. What is the underlying cause of maple syrup urine disease? So this is going to be a deficiency of the branched chain alpha keto acid dehydrogenase complex. That's the long one to get. So you have alpha keto acids in the urine because you can't break down those amino acids like leucine, isoleucine, and valine. Remember, these are the branched chain amino acids. All right, guys, that brings us to the end of our lecture, and I hope you learned something. I'll see you next time.
Hello there. Let's play a little game. I've got a treat for you. I'll give you 3 clues. See if you can guess the condition. 1. It is caused by deficiency of the enzyme alpha keto acid dehydrogenase. 2. It leads to a buildup of the 3 branched amino acids isoleucine, leucine, and valine. 3. Last hint. It can cause mental retardation and death. Oh, that's right! It's maple syrup urine disease. The name comes from a sweet, distinct maple syrup-like smell from the patient's urine. Oh, honey, you want some more? What? Oh, where are you going? Oh, well, more for me.